the importance of transitioning, because we have so many kids that once they become 18, they lose their insurance, they get dropped off everything, stuff happens and we expect that they're all of a sudden supposed to know everything. So have we been able to equip them with all the tools that they need in order to be successful? What I have learned in the 10 years that I've been in this agency is that we need a comprehensive approach to sickle cell. It is not one person or one thing or one entity. It starts with the child. The person, the child that is born with sickle cell disease. We were fortunate to find Dr. Shaw. Dr. Mervyn Shaw is joining us from Duke University. He has come and traveled, and let me tell you, when I say that this event was sponsored today, when I tell you that I offered Dr. Shaw, I'm sorry, sir. I'll give him a scholarship for coming today. Do you know that he refused to accept that from us, and he wanted to come and be with you all today and share his heart and the research that he's done and the things that he's seen, the information that he feels to be beneficial to you. And I tell you that this gentleman is accomplished. He is a professor. He is a medical professional. He has led research. He has more than 100 publications. More than 100. And I asked him to come and share this day with us for World Sickle Cell Day. And he had a lot of invitations. And there were a lot of people that wanted to spend time with him. There were a lot of people that wanted to hear from him. And he chose to come and spend this afternoon with each of you. That we will hear from Dr. Mervyn Shaw, who will, you have a PowerPoint presentation? Straight from here. All right. We're going to have a wonderful conversation. I'm going to get to the point.
Thank you so much. First of all, I appreciate the opportunity to talk. As was introduced, I take care of both kids and adults. I'm in a unique situation. I was medicine and pediatric training. I take care of babies. I take care of young adults. I take care of patients who are on the older end of the spectrum, who are really showing us that we are getting to a point where we have more and more success. When I say success, success is for my patient to do what they want to do. And so I focus most of my visits on what do you want to do, where do you want to go. So there are 3 things I want to offer today. And as I said, I can both kids and adults, so I take care of pediatric patients, adult patients. I run the transition program. I'm very lucky I can walk my pediatric patient to my adult clinic and say, this is a new clinic. There are differences. The adult clinic is a little bit more stark, and they don't have the colorful walls and the paintings, and they don't have music therapy. But we're trying. But the 3 things I want to pass on today is I'm going to have a conversation. This is not a PowerPoint lecture. I'm here to talk. I already have so many things I want to say based on what was already said that it's going to take a long time. So I'm going to just jump in. 3 things I want to do here. I want us all to focus on learning about sickle cell. I want us to focus on educating about sickle cell. And number 3, I want to focus on empowering us about sickle cell. So if we learn, I learn every single time I give a lecture, every single time I meet a patient with sickle cell. I want all of us to focus on the fact that we should learn as much as we can, because the next step is to educate others. Educate those around us, educate patients and their families, educate medical providers. You will, without a doubt, go to an emergency room or a medical facility and find someone who does not know as much as you know about sickle cell. It's unfortunate, but it does happen. And then the third thing is to empower, give that knowledge to that person, who then have them feel forward. You're empowering not the patient to advocate for themselves, but empower that medical provider to know what you know. So those are the 3 things I want to hope to go today. And it's in the context of differently. We have to talk differently. So when we educate the same way, we have to make sure. Because when I am in a room with a patient and family, anytime we go, yeah, Dr. Scott, I get what you're saying. I understand what you're saying. They're not. They're trying to be polite. They don't want to tell you, Dr. Scott, that I don't understand what you're saying. So I have to make sure I explain. So that's what I'm going to do today. I'm going to go through 3 things in how I teach. So yes, we're going to learn, educate, and empower. But when I go through transition, I go through this idea of the who, what, where. Who we are with the disease. What do I need to know about sickle cell? And where am I going in life? And where is it that I need to make sure I think about the problems that I'm becoming? Okay, so let's start with the first question that often comes about transition, which is, when do we start talking about transition? Now, there are some mindsets that you should start as soon as birth. There's a lot of other things to think about when we talk with leaders and that upcoming teenagers. But by 12 to 13, we should be talking about transition. Transition is a process. They should not be talking to you about moving to the adult world when you're 18 and it's your last visit. That is way too late. Because we need to get all our patients' families ready for transitioning and transferring. So I'm going to be very careful about that. Transferring is handing the baton off. We're handing all this information to the adult world. But you have to be ready for that. You have to run that whole marathon, that race, to get to the point where you can hand that baton off. So, the who is knowing the basics. At age 12 to 13, I want that patient to have some ownership of what sickle cell is. At age 12, I always ask my patients, Jimmy, do you know why you're here to see me? And he's like, I don't know, but I'm here. I didn't miss school. Let's think about it. Let's think about it. You're here because you have sickle cell. You know what kind of sickle cell? It's important to know your what type of sickle cell. Like SS, SC, S beta thal. There's actually several different other more rare types. You just have to understand what type of sickle cell. That's the first way of identifying that they know. I got sickle cell and I'm type SS. They should be able to recite that very easily. Next, they should know how they got sickle cell. Got it from mom and dad. Mom had trait, dad had trait. I got it from mom and dad. It's not something you get as a cold. They don't get it from somebody else. It's not contagious. They need to understand you got it from mom and dad. Next, you need them to understand what are the issues that can cause more problems with sickle cell. So cold temperatures, very hot temperatures, changes in barometer, which means when it's about to rain, you can feel it. Those are things that you need them to understand. Dehydration, drinking lots of fluid. That's a drink like a fish, eat like a horse. You're going and going and going. So you need to make sure that your teachers know that because they need to give you the opportunity to go to that. I'm telling you that. Other things that they need to notice infections and breathing issues can cause problems. If you have a cough and a cold, it may be okay, but you need to let mom know that you're not having problem breathing or having an issue with your potentially oxygen breathing. So those are the basics with the who. And then the last thing is I start to get them to understand what sickle cell looks like and what it is. So I draw on the exam room table all the time. We should be making things very visual. Kids are very visual learners. Next to the point, I will also say I don't give lectures to my kids. All my patients, I don't give lectures. What do they do? They watch 30 to 60 second TikTok videos now, right? You have 30 to 60 seconds to get that attention and information across. I'm going to take a break. Come back. So you want to draw these pictures out. And again, speak in a way that they understand. When I talk about the different types of blood cells, it's very easy. Red, white, and blue. You got red, white, blue right here in the room here. So red blood cells, those ones like the sickle, they carry oxygen to get energy to the body. The white blood cells, they fight infection. And blue is what are called platelets. They actually help you stop bleeding. Red, white, and blue. And then I come into the room and I say, look, this is what your slide looks like. This is what your blood looks like under the microscope. I want to bring that in and have the patient see what their blood looks like. And so there's a red blood cell, there's a white blood cell, there's a platelet, it's the blue. And you're getting the patients to really start feeling invested in what's happening. And then the parents are like, oh yeah, this is kind of cool. Jimmy starting to get it. So So you want to talk in a way, and then you want, it was brought up before as well about the red blood cell being kind of like a donut. You brought that up. And so I go to the next level. It's like a jelly donut. It's nice and squishy. If you took a bite out of that squishy donut, what happens? You get a sticky jelly on the side, right? On that sticky jelly, then things get stuck. And the patient gets to understand what's happening on the inside of it. And blood doesn't go to where it needs to go. It's a problem. If blood doesn't go to the bones, it hurts. Blood doesn't go to the lungs, it's acute chest. The number one cause of things going bad quickly. Blood doesn't go to the brain, it's a stroke. So those are all, it all ties back to the sickle cells not getting. So that's the root. And I'm going to get that into my patient's mind, and I'm going to have to remind them over and over. At 12 to 14, that's what I'm doing. 15 to 16, we get into the what? What do I do? What are the conversations? What is my pre-action plan? What are my medications that I'm on? And we'll get into this because a lot of conversations happen about gene therapy, transplant, medications. But we need our patients to know what they're on, when they take it. Even if they're on pain meds, they should know. Even if they're not dispensing it to themselves, they should know what pain meds they're on. And it's all about self-activates. So this what is now 15 to 16 because they're starting high school. They need to know. They're going to high school, they're very independent. They're really trying to do things on their own. So that's the what, and what are the complications? Now I'll tell you the story because it really resonates with me why I do this. I tell my patients, if you're at risk, I can really imagine this is going to happen to you, it's a rare side thing. You're at risk for a stroke. Having blood not getting to your brain is a stroke. If you have issues with talking, with issues with visual issues, if you have problems with weakness on one side of your arm or leg, you have a really bad headache that doesn't go away, you need to let a doctor know. And you should, when I go to the next extreme, you should expect to go to the hospital and do what's called an exchange transfusion, which means there's a machine next to you that's going to filter out the sickle cells. Because if I'm worried about stroke, I got to get that sickle cell out of it. So I go through all these steps. The story is that I get this all the time. I had a doctor 2 hours away at home, and I remember very vividly. I was walking onto the soccer field from my doctor, I coached her, and I got this call from this doctor talking. And I answered it. What's going on? I said, Dr. Shaw, your patient's here. She had a really bad headache. We're worried she's having a stroke, and she keeps talking about this machine that should be next to her. And I was just impressed that my patient is telling this doctor who didn't know sickle cell. She remembered what I said. She didn't know what the machine did. She just knew she gave her machine next to her. That's fine. And so, the short story here is she had a stroke, thankfully, we worked out, we got her to do everything worked out, she didn't have a stroke, but she knew what needs to be done. That's why we do this. That's why we have these conversations. To make sure that patient and the family, and the mom didn't know what was going on. Mom was like, I don't know, she keeps talking about this machine, that's what we're calling it. So we need to make sure you have these conversations of what are the complications. If it's a stroke, acute chest syndrome, if it's pain crisis, talk about these complications so they know what are the things that they need to consider. And then the where, 17 to 18 years old, talk about where are you going in life. And I started this earlier, but we want to talk about what do you want to do? I had a clinic just earlier this last week on Wednesday, and my pediatric clinic asked, what do you want to do? He was like, Dr. Shaw, I haven't really thought about it. You're 14, 50, you need to start thinking, where do you want to go when you finish high school? What do you want to do? Well, you know what? I do kind of like drawing. That's amazing. Bring me to art. Show me what you got. And let's talk about what college you can do to do some digital design. So, yeah, I do like computers. Start stimulating that concept. So where is it going? How can I support you to get there? And I go to the point and say, well, I know you talk about community college, but you go to the application. What is the community college you're talking about? When is the deadline for that community college? Push them a little bit. They're not going to listen to mom sometimes, right? But the doctors or family, they're going to listen to them. So we want to push them to where they're going. Now, if they can't assure you that they're going to go to school, where are you going to work? Are you going to volunteer? Are you going to volunteer at church? What can make you productive and happy in what you want to do? Again, going back to, I want you to be successful. I've had 16-year-olds just recently graduate from high school, go on to college at 16, became a social worker, and now is a social worker for sickle cell. Amazing. It's so You'll notice by the end of this time. I love it. And the reason, one thing that I want to offer here, I mentor a lot of residents, students, fellows, anyone who's interested in sickle cell. I bring them in. Let's talk. When they go in to see a patient with sickle cell, I challenge them. Go into it. I know we talk a lot about pain. Pain has come by the and is without a doubt is a major issue. No more reason for hospitalization, no more reason for things that we need to address. But sickle cell is not just pain. Sickle cell has a lot of other things that need to be addressed. So I challenge my learners, when you enter the room, don't talk about pain. Talk about everything but pain for as long as you can. 20 minutes, 30 minutes, for as long as you can. Talk about everything else. Talk about boyfriends, girlfriends, talk about school. Talk about what you do in the summer. Because you want them to identify you as a healthcare provider. They're coming to the doctor not for pain only. So you need to get them to understand everything else is important just as much as understanding the pain action plan. There's of course a pain action plan. Everyone, pain plan should be different. It's individual. So that's my transition discussion. Kind of boil it down because I can't hold back. There's a lot of questions that can come up during this first questions that I can on conversation. And I want to give time for questions as well. There's military presence in the room here, so we're going to stick to our time a little bit. But what I want to offer a couple things here. So the first is, we have come a long way. We've definitely come a long way. Within the last 5 to 10 years, so much more research happened. So much more research happened. And that's clinical trial need to continue. But there's actually gotten to the point where we've gone from 1 medication that was approved to 4 approved medications, and now 2 gene therapies are approved. Now, I'm going to get into the gene therapy just a moment. But let's just start with 4 therapies. I'll be very general because I'm not going to be specific here. Hydroxyurea is a medication we started 9 months ago, very early. And we have oxyurea approved, an oral medication that helps you bring up your hemoglobin to 4 over. L-glutamine is an antioxidant. L-glutamine means that we get at the GNC store, but there's a pharmaceutical version of that, and it's an antioxidant, helps improve pain, improve fiber. And then we have one other IV medication supposed to prevent pain for 16 years, so that. So we have these 4 medications. I will say right here and now, it's not enough. We need more. And there's more coming, but it's a good start. Now the problem that often happens is that they'll start, for example, hydroxyurea, they'll start oxyurea, and they're like, it's not working, it's not working. It may be working, but with sickle cell, it's a chronic disease. It continues to work on the body. So almost no matter what you do, you still got sickle cell. And sickle cell's gonna, your body is finally gets upon the body, body's like, I'm trying to make all this blood. I just can't keep up. And as you get older, amazing, I think, to see you as you are right now. So with that many years, and have your body just get through this, an amazing thing to see. And we're seeing more of that. Because, and you, amazing, I'm just smiling, so it's a huge smile to see you. Because we're seeing more of the situation where patients are surviving longer because these medications are protecting through a period of time. Now, what we need to do is act as early as we can. So I will offer that. We'll offer it as soon as we can get you into care. I would encourage you, I'll share my email anytime. I always share my email with everybody. If you Google my name, it comes up. So it's no secret. So always look me up in email. Because I want to offer you, you need a local person, I'll find you. You need some advice, I will give you the best advice I can outside of a medical visit, but I will get you to the right person. One thing that we just had a recent push for is in our group, and I brag about this, she's someone that is a men's aid mom, but she's focusing on geriatric sickle cell. That's her specialty. The fact that you can say geriatric and sickle cell in the same sentence is just amazing. We weren't able to do that. So we are making progress, definitely making progress. So let's just talk about, because it can't come up a couple times, about curative therapies and gene therapy. I know this is going to come up in the main one. But I want to be a little bit cautious about gene therapy. I'm very optimistic about what's coming, First, gene therapy is a near cure. It's not a cure. It's a near cure. The hemoglobin gets close to normal, not normal. The increase in the fetal hemoglobin, the baby blood is protected to about 40%, which is amazing. You can be very protected. But it's not for everyone because I have to give you chemotherapy to then make room for this new bone marrow. Now, the difference, again, just as a very general description, standard transplant, I'll start here. Standard transplant is in someone else's bone marrow. It has to be a perfect match. That doesn't happen very often. It's very hard to have a matched sibling donor. You have a sibling for a patient with sickle cell, get touched. Without a doubt, get touched. 5% or so will be a match. It's not a huge number. Anemia, 5%. Then, if you do have a match, you will clean out the bone marrow with chemo, and then you get that person's bone marrow, and that's a bone marrow. A couple things can happen. One is you can reject the bone marrow. Number two, you may take the bone marrow, but then the bone marrow you get may fight you. That's called graft versus host. There's all these immunosuppressive medications that suppress your immune system. And then finally, it may not be a good fit. But if all that works out, it's a cure. Without a doubt, amazing good works. Now I have gene therapy. Same thing, but the nice thing with gene therapy, optimistic, and we'll talk about pros and cons here, is that I take your own bone marrow out, the patient's own bone marrow out, I change the gene, it's very cool, it's like on the science side, we're going to allow you to change the gene to turn on the baby blood. Get the baby blood to 40%, so protected. And then I get that bone marrow back to you, which is your own bone. So you're not going to reject it. You're not going to have graft versus host. But you still got to get chemo. You still got to get chemo. That's my hesitation. Because it's already shown that in sickle cell, patients who get chemo with sickle cell have a higher risk of having secondary malignancy, secondary cancer, and leukemia, 10 years later. That's already been established. So now, and it makes sense to a certain degree if you think about it. The bone marrow is so active, it's so revved up, it's just trying. And so it's all so crazy active. And then you add some chemo, that's not good news. Not good news. And that actually gets worse as you get older. So according to what you were saying, at 75 years of age, as wonderful as you look, I would not consider that light. Now, I'm always very optimistic where we're going because I can see the path. And I will say, cystic fibrosis, which has 10 times less patients, maybe only 10,000 patients in the United States, has 3 to 4 times more funding than sickle cell. That's changing. Only in the last 5 years. It's changing. So we're finally getting to the point that there's recognition. The reason that's important is that now even newer versions of gene therapy are being added. Not newer drugs too, but newer versions of gene therapy. So I talk to my patient, and I will say this too. Every single doctor you see that is a sickle cell specialist needs to tell you about all the options. Many don't do it, but they should tell you. There are 4 approved therapies, there's 2 gene therapies. Tell me about it. They gotta be telling me. Now, I tell my patients, okay, these are my 4 approved therapies, these are gene therapy. I am group you in this 1 of 3 categories. 1, you have so many risk issues, I gotta do this gene therapy now. I'm willing to take the risk. And I had one of my patients who he's 16, he had been amazing up until about 14 and a half. He started having a lot of pain crisis, he had 2 acute chests, once in the intensive care unit with one of those acute chests. I'm worried. So I talked to him, we had a long conversation, we talked about he's going to go on to gene therapy, he's going to do it. But it's not a light conversation, it's a long conversation. Another thing I didn't bring up, which is a reality too, chemotherapy causes infertility, 90-95% rate of infertility. Not a light discussion, it's an important discussion. And sperm banking and egg harvesting is expensive. It's supported, we can get support, and I've got support for 2 years. What happens after? Well, I'll get to that, but it's still a hard conversation. The second group is I tell my patients, I'd love to give you this gene therapy. It is a near cure. I'm going to get you out of this situation they figure that out, then the doors open for me. There was another that was just presented a couple days ago. There was a new version of the gene therapy that was pretty much cured. Still chemo. Hemoglobin normalized, so there's more stuff coming. So most of my patients fall into that category, where I can leave. In my last category, there are a handful, there's a fair number of my patients who are doing just fine on hydroxyurea, oxalate, whatever plan I got them on. And I'll just let them go for it again. Again, it's not right, we're going to go forever, but for a period of time. Okay, so I have gone into transition, and again, I wanted you to learn a little bit about sickle cell and how I talk to them, because when you educate your patients and family, you need to talk in a way that it translates. You want to make sure that they understand what you're saying. And I really, really am thankful to be able to be here, because I want to empower each of you in the way that I feel like my job is to have you pay it forward. Our job is always, and that's what we're all here in the room today. We hear because we want to pay it forward. We want to make sure that we can really not only learn and educate about sickle cell, but we want to empower our community to know what to do next to make sickle cell patients and families peaceful. So thank you. If it's okay, I do military time. I'm doing okay. Love it. Just answer questions. Thank you guys. Thank you.
Lots and lots of information with us, and I want you to feel encouraged, because I don't know how often we'll have the opportunity to have someone with Dr. Shaw's experience that will have this one-on-one dialogue with. So don't be shy. If there's anyone that has any questions, I'm happy to share.
My name is Valentine Joseph, and I am the founder of JJ Foundation for Women and Children. I lost 3 brothers to sickle cell. My only daughter has sickle cell. Nephews, cousins. This conversation we just had, it wasn't just a slide. You were talking to me, and I'm so grateful for that. Thank you.
You and all the others that are doing second and third time jobs, because we are doing this because we're passionate.
Thank you, Dr. Shaw. You know, I see a lot of people with sickle cell trait, and I hear in the medical community that sickle cell trait is asymptomatic, there's nothing to worry about, they don't have the disease, and then I have people that are full of disease. And there are just these communications that I'm not neurochemist, I don't have the experience that you do, but I hear certain things that cause me to pause. And often, when I see people with sickle cell trait, depending on the number of sickle cells that they have, they experience anemia, they experience so many things. Can you speak to that, Dr. Shaw?
Yeah, so it brings up 2 things that I think are really good to highlight. So one, it resonated with me about the trait, not being known. So let's just talk numbers very briefly, just from a numbers standpoint. It's 1 in 365 Black and African Americans in the United States have sickle cell disease. 1 in 13 to 1 in 11, depending on the state, Black African Americans have the trait. So almost 1 in 10 have the trait. That's a lot. And so the brought up too, there's different types of sickle cell, and I heard full-blown sickle cell a couple times now. I ran a panel a couple of years ago to try and understand what would make a patient be considered severe versus someone who's not severe. One thing I got out of it, I had a bunch of experts in the room, from pediatricians to family doctors to sickle cell doctors to patients. We all came to the consensus that we don't like the language severe sickle cell. The reason is every patient with sickle cell can be severe at any given moment. It can go into the wrong direction quickly. So by labeling someone as severe, or probably more so, if I label someone as mild, because they have sickle, they got that, or even SC, if I label them as mild, that's a bad connotation, because they can still have severe complication. And then they're going to go to the emergency room and say, oh, it's you got mild sickle cell. Don't put that label on a patient. I want a family to have to overcome that struggle. So I'm not a fan of using severity. You have severe sickle cell. You have sickle cell. That's it. You have sickle cell. It can be severe at any time. I have, unfortunately, I've done this for almost 18 years now. Just sickle cell. Really, just sickle cell for 18 years. I have too many stories where patients come in, talking to me, joking, having fun, and the next day they're in intensive care unit because it was a chest. It just turns around. And again, they come in and they were mild sickle cell coming in the door to the emergency room for pain crisis. But then they're severe. The next day in the intensive care unit. So we cannot label it as non-moderate severe. Now, maybe that academically, but I would not, I hesitate to call someone severe or mild, just because I don't want others to feel that they're not severe. Every patient
When I started working at the foundation, 1 year we were